In the last lecture, we covered anatomy and physiology of the pancreas and sonographic principles. This time we're going to cover the pathology of the pancreas. So pathologies that you want to be familiar with. These are things you're going to see possibly on the quiz, definitely on the midterm, and you will run into them when you take your specialty exams for ARDMS. We're going to talk about acute pancreatitis, chronic pancreatitis, and the difference between the two. We'll talk about pseudocysts, hemorrhagic, phlegmonous, pancreatic abscesses, multicystic disease, and then neoplasms, cystic pancreatic neoplasms, endocrine pancreatic neoplasms, and metastatic disease in the pancreas. All right, so acute pancreatitis. This is going to be an inflammation of the pancreas, and it can be chronic or it can be acute, and it can be classified further into anywhere from mild to severe. So what happens is the pancreatitis occurs when the pancreas gets damaged and it starts to malfunction as a result of the increased secretion and the blockage of the ducts. So what happens is the pancreatic tissue starts to be digested by its own enzymes. If you'll recall, I told you that pancreatic juice is highly alkaline and it's very caustic. If it's anywhere other than where it's supposed to be, which is in the ducts or in the duodenum mixing with gastric acid, then it's going to be able to necrotize and digest our organs. So this is why it's such a serious problem. The inflamed acini, remember those acini cells are the ones that create the pancreatic juice, release the enzymes into the surrounding pancreatic tissue, and everything just becomes inflamed. Pancreatitis is caused by a number of things, but the most common cause is going to be biliary tract disease. In 40 to 60% of patients with acute pancreatitis, you're going to see gallstones. And with the onset of symptoms, they're going to have severe epigastric pain that is accompanied by nausea and vomiting. And in patients with gallstone pancreatitis, the pain is going to be very well localized to the epigastric area, and it's going to be a rapid onset, typically reaching maximum pain in 10 to 20 minutes. The second most common cause is alcoholism. It used to be the most common cause, but it's been surpassed by biliary tract disease. With alcoholism, the onset is usually not as abrupt, and it's going to be poorly localized. It's a more generalized type of pain than gallstones. Okay, pain can radiate to the back. It can persist for several hours to days. The nausea and the vomiting can be unremittent, meaning it's severe and they don't get any relief. Okay, and other reasons that you may see pancreatitis is going to be things like trauma, inflammation from an ulcer, abdominal infections, pregnancy. Pregnancy causes oh so many wonderful things, and one of them is acute pancreatitis. Mumps, tumors, there can be congenital causes, vascular thrombosis or embolism in the arteries and veins of that feed the pancreas, and then also drug use. You're going to see elevated serum amylase and elevated serum lipase in patients with acute pancreatitis. The lipase elevations occur earlier and they last longer compared with the elevations in amylase, and so they're especially useful when patients are seeking treatment more than 24 hours after the onset of pain. So this is what it's going to look like. We're going to talk about each of these, but typically with acute pancreatitis, the organ is going to be hypoechoic to the liver, and it's also going to possibly be swollen or edematous. So the borders may get fuzzy and become a little less distinct. As you can see here, they get this sort of irregularity to them. They can stay smooth, but here we have edema. See these right here where my laser is, and right here you see these sort of anechoic invaginations into the pancreatic tissue. That's edema of the pancreas. And here we've got a very swollen pancreas and edema. You'll see the arrow is pointing to some edema. I'm going to trace this pancreas for you because it's a little hard to see. So here goes my laser pointer all the way around. There's the uncinate process, head, neck, and then down body, and then tail down here. So you can see that it's going to have what we call an irregular or heterogeneous texture to it when you've got pancreatitis. But pancreatic enlargement and decreased echogenicity are going to be your sonographic landmarks for acute pancreatitis. Those are the two things you want to remember: enlargement and decreased echogenicity. We are not actually as good at diagnosing early acute pancreatitis as CT. CT is the gold standard, but we can demonstrate it as well. Now, chronic pancreatitis is a little different. This is going to be the result of recurrent attacks of acute pancreatitis. So they've had a pancreatitis a number of times, and they end up with chronic pancreatitis. This can lead to impairment in both the exocrine and the endocrine function. So they can become, they're at a higher risk for developing diabetes mellitus and also for developing pancreatic cancer. There's usually permanent structural damage with chronic pancreatitis, and it's going to be damage to that parenchyma, so they're going to always have sort of a heterogeneous texture to their pancreas. Okay, it's usually associated with chronic alcoholism or chronic biliary disease. So if someone has known gallstones and they've refused surgery, or they've passed several gallstones, they're going to be more likely to have chronic pancreatitis. And 25 to 40% of them are going to also have pseudocysts. They may also have a dilated common bile duct. They can have thrombosis of the splenic vein with extension into the portal vein. And as we said, it's going to increase their risk for diabetes and for pancreatic cancer. So you'll recall we just said that with acute pancreatitis, we get enlargement of the pancreas and it'll be hypoechoic to the liver. With chronic pancreatitis, we actually get the reverse. We're going to see atrophy of the pancreas. We're going to see a heterogeneous texture with hyperechoic and hypoechoic areas. And typically we see a lot more scarring and fatty infiltration because of those recurrent attacks. So the pancreas is typically hyperechoic to the liver at this point. It's going to be increased. The echogenicity will be increased beyond the normal because of those fibrotic changes that you're going to see. Okay, complications. Complications to pancreatitis include pancreatic and parapancreatic fluid collections. These are going to be walled off fluid collections. Another name for them is pseudocyst. Okay, pseudocysts are going to develop in 10 to 20% of the patients that have acute pancreatitis, and typically 4 to 6 weeks after the onset of pancreatitis. They are always acquired. They're never going to be congenital. Okay, so they're never going to be there at birth. They're always acquired, and they result from trauma to the gland from the acute or the chronic pancreatitis. Sometimes those fluid collections will resolve spontaneously. That's great. If they do not, then that's when we call them pseudocysts. Okay, so what happens is it's a reaction of our body to try and control the damage. Remember I said that juice, that pancreatic juice from the acini cells, is going to destroy or damage any tissue that it comes into contact with. It's going to start to digest it and necrotize it. So what happens is we get a walling off of the fluid. Our body walls it off and contains it so that it can't spread and cause greater problems to the peritoneum. Typically, where you're going to find these is behind the lesser sac, okay? The most common location is in the lesser sac, anterior to the pancreas and posterior to the stomach. The second most common location is going to be the anterior pararenal space. And we see it more in the left than in the right because the pancreas extends to the left towards the spleen and the left kidney. Okay, so there we go. Lesser sac, anterior pararenal spaces. Other spots you might find them will be the mesocolon, perirenal spaces, and the peripancreatic soft tissue spaces. Sonographically, well, we'll get to that. Let's go on to pseudocyst, okay? So we talked about if they last more than 4 to 6 weeks, right, then they are a pseudocyst. This is a collection of fluid that arises from the inflammatory process. It's going to contain areas of necrosis, trauma, or hemorrhage. And as we said, the enzymes escape, they break down the tissue, and they form a sterile abscess in the abdomen. The wall of the pseudocyst is not like a true cyst wall, okay? So think of some of the things we've looked at before with a cyst, right? They're circular, they got a smooth, well-defined border with posterior acoustic enhancement, and they're anechoic. Pseudocysts tend to take on the contour of the available space, so they're not always going to be nice and round, and there can be more than one. And as we said, the lesser sac is where you're going to find them most often. Okay, now those pseudocysts can rupture, and when they do, we call it pancreatic ascites. This is a consequence of the spontaneous rupture of the pseudocyst, and it occurs in about 5% of patients. In 3% of the patients, that drainage is going to be directly into the peritoneal cavity. And in 2%, it will be into the gastrointestinal tract. Okay? So typically when we see these, you'll see a typical pattern for pseudocyst formation, but the patient could have intense pain secondary to the rupture. Clinical symptoms are going to be peritonitis and sudden shock, and the mortality rate on this is high. It's about 50%. 50% is the mortality rate for pancreatic ascites. Okay, so pseudocysts, what are they going to look like? We've got, now these ones tend to mostly be pretty spherical, right? We're doing pretty good here on the spherical side, but notice we've got some fluid here. We got this big pancreatic pseudocyst. If you're trying to figure out what you're looking at, liver's up here. This is liver. Okay. Pseudocyst is here. Aorta is here. Pancreas is here. Okay. And then on this one, same thing. Pancreas here. We've got the pseudocyst. And here we've got liver at the superior portion of our image, pancreas again, and that pseudocyst sitting posterior to the pancreas in this case. All right, hemorrhagic pancreatitis. This is a rapid progression of acute pancreatitis with rupture of pancreatic vessels and then subsequent hemorrhage of those vessels. So there's diffuse enzymatic destruction of the pancreatic substance caused by the escape of those enzymes into the glandular tissue, and they're going to cause areas of focal fat necrosis in and around the pancreas, which then leads to the rupture of those vessels and the hemorrhage. Most of the time we see this in patients who have had an alcoholic binge or an excessively large meal. So yes, you can eat too much and destroy your pancreas, okay? So The sonographic findings are going to depend on the age of the hemorrhage. A well-defined homogeneous mass may be seen with fresh necrosis areas. The necrosis areas are going to be anechoic, okay? But the fat necrosis, the fat and the focal area is going to be bright usually, which is what we have here. Okay, here's liver up here. We got the pancreas here. Okay. Everything with a P is pancreas. This is that superior mesenteric vein. Okay. And what you're seeing, notice this bright area of the pancreas right here. This is pancreatitis with hemorrhage. Okay. So phlegmonous pancreatitis is another complication of pancreatitis, and it's an inflammatory process that's going to spread along those fascial pathways. So remember, we have all that myofascia in there, in the abdominal cavity, in the peritoneum, and it lies in sheets. And what you get is diffuse inflammatory edema of the soft tissue along those pathways, so it's going to look sort of stringy or sheet-like. It'll be in layers, okay? That edema can lead to necrosis and suppuration, okay? We're going to see this in about 18 to 20% of patients who have acute pancreatitis, and on ultrasound, it's going to appear hypoechoic with good through transmission, and you will see it lying in sheets. So what you're looking at here is, here we've got the right kidney, and here we've got all this phlegmonous inflamed tissue, and see how it sort of seems to have like layers that run across the screen. Okay, that's going to be the phlegmon. So pancreatic abscess is another serious complication of pancreatitis. Fortunately, it has a very low incidence, but it can happen a lot of times post-operative. So what happens is they have surgery and then they get acute pancreatitis as a consequence of the surgery. Abscesses can arise from neighboring infections such as perforated peptic ulcers, appendicitis, or again, acute cholecystitis, which is gallstones, okay, or gallbladder disease. If it ruptures, you can get acute peritonitis, and that will be an abscess then in the peritoneal cavity. Pancreatic abscess, if it's left untreated, has a very high rate of mortality. Okay, so they have to treat this, and they have to treat it quickly. That covers pancreatitis and all the complications and ways that it can get much worse for people. We're going to talk about multicystic disease next, and there are a wide variety of lesions of the pancreas that you can see on imaging studies. The cysts can be either non-neoplastic or neoplastic. Neoplasm just means it means new growth. It can be cancer, so it's a tumorous growth, okay? So we're going to talk about the different types of multicystic disease. The first one is autosomal dominant polycystic disease. This is characterized by multiple small cysts in the kidney and the liver. Typically, those are the organs that it's going to affect, but on occasion it can affect the pancreas as well. And the cysts can be microscopic to several centimeters in diameter, and as they increase in size, they're going to destroy the normal parenchyma of the pancreas. So they're going to destroy the normal tissue. Von Hippel-Lindau syndrome is an inherited disorder, and we're going to see it characterized by the formation of tumors and fluid-filled sacs in many parts of the body. but they do affect the pancreas as well. The tumors can be non-cancerous or cancerous, and mostly they're going to appear during young adulthood, but the signs and symptoms can occur anytime throughout life. The tumors are called hemangioblastomas, and they're growths that are formed by newly formed blood vessels. So they're usually not cancerous, but because they are formed by blood vessels, they can be serious and have life-threatening complications should any of those vessels burst, because they are much more fragile than normal blood vessels. Okay, and then the last one is cystic fibrosis. This is another hereditary disease that causes excessive production of the thick mucus by the endocrine glands. So it can affect any endocrine gland, and because the pancreas is both an exocrine and an endocrine gland, it'll be affected by cystic fibrosis. What we're going to see is fatty replacement of the normal pancreatic tissue, and often we'll see calcifications in there. There can be cysts that develop from the mucin that obstructs the pancreatic ducts. So the duct gets obstructed, and then we end up with a cyst. They can be single, they can be multiple. Most of them are going to be microscopic, but they can also be several centimeters in size. There are 4 types of cystic pancreatic neoplasms that have varying potential for malignancy. Okay, so we've got serous cystic tumors, mucinous cystic tumors, intraductal papillary mucinous neoplasms, and solid papillary neoplasms. Okay, cystic neoplasms account for 10 to 15% of all pancreatic cysts and less than 1% of pancreatic malignancies. So the serous ones, we're going to talk about those first. These are rare, they're benign, they're going to be well circumscribed, so they'll have a nice clear wall with multiple tiny cysts. We see them most often in elderly females, and they're, like I said, very unlikely to develop a malignant potential. So these are going to be your serous cystadenomas. Okay, now your mucinous cystic neoplasms are also uncommon. They're slow growing and they arise from the ducts. Okay, again, they can be malignant or they can be benign with malignant potential, which means that they have the opportunity to turn malignant. And again, we're going to see them most common in middle-aged to elderly females. Okay. The mucinous cystic neoplasms, those are the ones that can reach, they can be very small, from like microscopic size up to 2 centimeters in diameter. Typically, you're going to see, again, well-defined cysts. You'll see thick mucinous fluid inside them. There may be internal septations. And you may see mural nodules. If it's greater than 5 centimeters, it has a much more increased likelihood of being malignant. Okay? All right, and then intraductal papillary mucinous neoplasms. These are a form of mucinous neoplasm that originate again from the main pancreatic duct, which everybody remembers is called the duct of Wirsung. They're slow growing. They do affect the elderly of both sexes, and they can be benign or malignant. Okay. There we go. Okay, so here we go. This is going to be a picture of this is the picture of the mucinous cystadenoma. Okay, and you can see we've got a fairly well-defined border, and we've got lots of areas of cystic necrosis happening in there. Okay, Here we go. This one is more cystic again. And this one, I believe this one is the one in the tail of the pancreas. And again, we're looking at, this is an intraductal papillary mucinous neoplasm. So here's the neoplasm right here. Okay, this is the spleen up here. Here's the border. I'm going to trace it for you. Okay, and this is happening at the tail, so it's kind of sort of right at that splenic hilum, if we're remembering our relational anatomy. All right, and yet another way that they may look, you may see a mostly cystic lesion with a little mural nodule in it. This is what a mural nodule looks like. It's going to be inside the mostly cystic lesion, and it's going to have a solid component to it. Okay, adenocarcinoma. Okay, adenocarcinoma is it's going to involve the exocrine portion of the gland, and it's the most common primary neoplasm of the pancreas. It's going to account for more than 90% of all malignant pancreatic tumors. So if you see a mass on the pancreas that you suspect is going to be malignant, chances are good it's going to be an adenocarcinoma. Pancreatic carcinoma only accounts for approximately 5% of all cancer deaths. Accounts for approximately 5% of all cancer deaths. It's the fourth most common cause of cancer-related mortality after lung, breast, and colon cancer. And the reason for it is because it's typically asymptomatic until it's reached a stage where it's much more advanced. And we don't, like, if they have no symptoms, we have no reason to image them. So if they're not imaged, then they don't see it until they have symptoms, and by then it's usually going to be have a high rate of mortality. Okay, it's rare before the age of 40. Most of the patients are going to be over 60 years of age. Prognosis, as I said, is very poor. Median survival time is going to be 2 to 3 months, with a 1-year survival rate of only 8%. This is improving because we're doing more and more imaging on people all the time, and so we're finding these incidentally when they come in for other reasons, and so we're diagnosing them earlier. Okay, clinical symptoms are going to depend on the location of the tumor. Pancreatic head, they're going to present symptoms earlier than if it's in the tail, because it's going to cause obstruction of the common bile duct, and they're going to end up with jaundice and high drops of the gallbladder. They're going to have high drops of the gallbladder is going to be an enlarged gallbladder, and the jaundice, of course, that's the yellowing of the skin. So you can feel the gallbladder. It's typically not tender, and that's going to be in about 25% of the patients with pancreatic carcinoma. Tumors of the body and tail, we have less specific symptoms because we don't get that impingement on the gallbladder and the common bile duct. So most commonly, we're going to see weight loss, pain, jaundice, and vomiting as the GI tract gets invaded by the tumor. So if the ones in the head are going to be more survivable because they're going to be found earlier, because they're going to present with symptoms earlier. The body and tail, those tumors are frequently larger in size, and they've already invaded adjacent organs by the time we find them. And these are multiple ways that you will see those adenocarcinomas. Each one of these is an adenocarcinoma. So let's start up here and start to identify some landmarks so we can figure out what we're looking at. Here that I'm tracing, this is the left lobe of the liver, just a tiny inferior portion part of it. You can see we got IVC here, aorta here. Immediately anterior to the aorta, that little anechoic ring with the bright hyperechoic ring around it is the SMA. You can see the splenic vein anterior to that running into that portosplenic confluence, and as we know, the pancreas sits in front of that. So I'm going to trace, here's the posterior border of the pancreas. Coming around, here's the head, neck, body, and then this whole thing is tail. And you can see we've got a large neoplasm growing on that tail. Okay. Down here, it's a little more subtle. We've got a pancreatic head neoplasm. That's what I'm circling right now and what the yellow arrow is pointing to. And then pancreatic tissue is here. Now notice we've got this big cystic necrotic area of the pancreas. What's happened here is this tumor in the head has compressed and blocked off the pancreatic duct, the main pancreatic duct, and you're seeing destruction of the pancreas from those pancreatic enzymes leaking out of that duct. This very thin hypoechoic line right here is the splenic vein. This tiny little dot right here is your superior mesenteric artery, and then we cannot see the aorta or the IVC. Okay, we've also got probably pancreatic neoplasm right here, this cystic area as well. And then up here, see the irregular borders of this neoplasm? They're not all nice and round. Some of them have these sort of extensions or fingers, we call them spiculations, that extend into the normal tissue. And again, we've lost really the normal like landmarks here. We've got liver up here, okay? We've got aorta right here, SMA above that, or anterior to that, and here's that splenic vein right here. But we've really like lost our normal pancreatic tissue that we would expect to see. You can see a little bit of pancreatic tissue here. We've got a dilated duct of Wirsung. IVC is down here. Okay, we're almost done. Hang in there with me. Endocrine pancreatic neoplasms. So we had two kinds, right? Exocrine ones and endocrine ones. Endocrine pancreatic neoplasms are going to include, they're going to arise from the functional islet cells of the pancreas. Remember the islets of the Langerhans, okay? And there's different types of islet cell tumors. They can be functional or non-functional. They can be benign in the sense of adenomas, or they can be malignant. The growth rate is going to be very slow on these, and they usually do not spread beyond the regional lymph nodes and the liver. The most common one is going to be your insulinoma. It's a functioning islet cell tumor, and what we see with these patients is they're typically somewhere between their 4th and 6th decades of life. They're going to have hypoglycemic symptoms, and they'll get immediate relief of the symptoms after the administration of IV glucose. Okay. The second most common is going to be the gastrinoma. And the gastrinoma is going to be a functioning islet cell tumor. It's produced by the Zollinger-Ellison syndrome, and it's caused by non-insulin secreting pancreatic tumors. They excrete excessive amounts of gastrin, which is why they are called gastrinomas. Okay. Gastrinomas are going to be seen in younger populations. They usually affect young adults, and because of the excessive amounts of gastrin, the stomach then starts to secrete too much gastric acid, and we see these patients often come in because of ulcer type pain. Okay, there are many others that are much more rare. Be aware of them, maybe take a minute and figure out what the main sort of defining characteristic of each of these is, but don't spend a lot of time on these other ones. And that's going to be rare islet cell tumors, non-functioning islet cell tumors, metastatic disease, Generally speaking, metastases to the pancreas is uncommon, but it can be found in about 10% of patients with cancer, and the primary tumors are going to be things like melanomas, breast cancer, gastrointestinal tumors, and lung tumors. Those are the ones that are going to metastasize to the pancreas. You can have lymphomas that arise from the lymphoid tissue, lymphangiomas, which include hemorrhagic and blood vessel characteristics. You can have paragangliomas and cystic teratomas. Okay, that covers pretty much all of the ways that things can go wrong with the pancreas.